If you are a physical therapist and you manage ACL return to sport decisions, and you want to know what am I missing, what can I be missing, and what else should I be considering before somebody goes back to sport? If that is what you're interested in, this episode is perfect for you. Hi, everyone. Welcome back to the podcast. Welcome to all new listeners, and welcome back to those who have heard my content in the past. If you are a physical therapist and you manage ACL return to sport decisions, and you want to know what am I missing, what can I be missing, and what else should I be considering before somebody goes back to sport? If that is what you're interested in, this episode is perfect for you. I am so excited to share a complex case study that was presented to me recently and is actually a very challenging case. And I think every physical therapist can benefit from hearing it and then sharing the lessons learned. And I'm going to do something a little different today that I've never done before. For those of you on my YouTube channel, I'm actually going to draw out the case study as I walk through it with you. For those of you on the podcast, I'm excited for you to hear the lessons learned. If you want to see my whiteboard session on how I would lay out the progression and you're more of a visual person, join on YouTube. Before I go on to the case study and onto the podcast and the show, I wanted to share life updates. I'm always about the human behind the professional. That's so important to me. If you don't know, I always like to start any meeting I have with team members, physical therapists, doesn't matter. It is positive focus. What is new? What's better? And what's better is we just had, my wife and I just had a great cryotherapy heat therapy based type of treatment and acoustic or magnetic acoustic therapy. That was pretty new to me and really cool to experience. So thank you to John from Cryo Republic in San Diego. So thank you for that. So coming off of that, and gosh, this concept actually came to me while I was getting treatment. What would I share with physical therapists who are considering return to play progressions? And what are the lessons that I've learned along the way? And this case study brought out a lot. And for those of you who don't know, I share these case studies with my team. And here's a couple lessons that I just shared with them, and I want to share with the world. So I want to talk about the case study first. So the case study is actually very common. I don't think it's that uncommon for a lot of us to see. It's the lessons and the takeaways that you have from it that helps you with future cases that you're going to have. So more than anything else, this is a challenging case, but consider it anytime that you have a return to sport progression. And this is particularly ACL, but actually can be applied to anything else. So to start off, we have a high school student with an ACL who is around, I think, almost 10 months. And ultimately, this individual is getting close to or wanting to get back to sport. And ultimately, they want to make a decision on what do I do next? And is it smart for me to go back to sport this soon? And what would you do? So ultimately, I said, hey, is this person safe? And I want to know the case, and I want to know, is this something that you would do? And would you do again, or what would you modify? So here's a case. We have a ACL with 9 months out, and they are looking to play in the next month. So they actually want to play. So the goal is to play at 10 months. Now, what would you do? Would you allow somebody to go back to sport at 10 months after an ACL? That really becomes the question. What would you do? You kind of have to sit on that, marinate on that. Do you feel comfortable? And it depends on what your progressions have been. Would you feel comfortable with it or not? And maybe you work in a very progressive facility or a surgeon that allows them to do that. And it's also your comfort level with the number of ACLs that you've seen as well, right? So here's the challenging part. We have somebody, I'm going to give you some variables. So the goal is they want to go back to soccer at 10 months. And is it safe for them? So now let me give you a couple variables. They do have a functional knee brace. They do have some measurements. I know this is literally where everybody wants to know, what's the measurement? What do you have in front of you? What do I have to play with? All right, so we have an ACL functional knee brace, and they have, here's some return to play testing scores. Everyone's going to be different. So ultimately, the return to play scores, we have a subjective rating, meaning they feel they are 95% better. Hop testing, single leg, double leg, vertical and linear hop testing is at 80 to 85%. Even with some test, triple single leg hops is at 100%. So now what is the quad girth? The girth is actually at 65%. What's the strength? Is at 60%. And what are questionnaire ratings? So when you look at all these things, the questionnaire was 90%. Now, when you look at this case and you look at, well, okay, if you look at subjective, okay, that's their mindset, that's their goal, that's how commitment, that's their will, I'll say. And on hop testing, what does that really test? Plyometrics, right? So, but what is involved in that? A lot of that is maybe nervous system. How ready are they? How powerful are they actually before they return to sport? And power output. And quad girth tells you mass, like where are they? And then manual muscle testing or dynamic muscle testing was at 60%. So that tells you absolute strength. And the questionnaire is at 90%. That tells you mindset and readiness to return to sport. So there's a couple things missing. So they have the will, their nervous system power output is good. They have the mindset, but there's two things lagging, right? There's the girth of the quad and the strength of the quad. What do you do? And we have somebody who's just about 10 months, and this are their measurements. Would you allow him to play going into 10 months? And some of you are going to be shaking your head like, no way, I would never do that. Now, when you have this person in front of you, we've all had this, right? You have the people who change your view on what you do. They look at you and they're like, I need to play. I want to play. I feel safe. I want it. And the parents are in line. So let me put that in there. So parents agree. Parents understand the safety and they understand the risk and risk. Okay. So what does that do? Okay. So if the parents and the athletes are on board, the will is there, the mindset's there, but the strength and girth are not quite there. So what do you do? And this is where, you know, we came together and we kind of set out a plan and a roadmap. And this is exactly how we did it. We looked at a whiteboard. How do we make this work? So what would you do? And you already have the numbers in front of you. So ultimately, there's a couple of lessons I learned off of this. And I want to talk about the algorithm first. I think that every physical therapist needs to take. So if you're fortunate enough to work with high schoolers or pro athletes or community members who are this far out, the question becomes, do you support moving them forward? And it's not an ideal scenario. I will tell you a story. One of the quickest ACLs I've been able to help get back to sport, 6 months. Now you're like, no way, there's not possible. This was a pro athlete and was playing rugby, and this was their job. And what if you're able to work with them, 2 to 3 times a day? Would that change your perspective? Well, maybe. Correct. So you can't say, you don't need to say like it's an absolute no. What you need to do is say, well, is it a maybe? Do we allow this person to go back to sport? So I worked with an athlete, a pro athlete, 2 to 3 times a day for 6 months straight, and allowed them to be able to get back to sport. Now, would I recommend that? No. Now, is that safe? I mean, as safe as you can possibly get, as long as the numbers make sense. Now, you don't know the resilience of that graft. and you want to make the best possible decisions. And in hindsight, now knowing what I know, there's a lot of things possible that we don't ever get to test. And some people's will is the difference. Like, they actually want to do it. Some of the quickest NFL ACLs that have gone back, they set some record numbers, and that's because that's their job. They're getting paid to do that. So their will kind of supersedes, overrides a lot of the other things. Now you might say, like, well, our job is to be a guideline, a safety net to get them there safely. Absolutely. Within the context of their goals. When they're a pro athlete, they're making the decision and the organization is making the decision. You're just getting them to the point where you're allowed to, and they have to make a decision on their own. And that's the pro world. Now, when you're a community member, you're actually looking for the safety, right? Especially a high schooler, right? You're trying to help them achieve their dreams. That's where you're caught. Everybody sees it that, they have this dream that they want to be able to play in maybe their final game or whatever it is. So what do? I think ultimately that you got to be able to provide a couple different roadmaps or options for them to do it, and everybody has to be involved. There's a couple parties that need to be involved. Number one, the athlete. First and foremost, they are number one in this whole game. Without them, we don't exist. This whole case doesn't exist, and we don't have jobs. So number two is the athlete. Sorry, excuse me. Number one is the athlete. Number two is the parent. In this case, it's a guardian, right? They're a legal guardian. They're like number 1B. You have 1A, 1B because they're not adults yet, and so you kind of have to work with them. So both of those parties have to give the thumbs up. They have the checkbox. All right, I'm in. So now, if the parent is in and the athlete is in, now we have to get the clearance. We've done the testing. Are you okay with the numbers? I mean, they could be better, but now we have to go to another member of this full circle of this athlete. Every time I work with an athlete, you always have to understand they're at the center, right? And if they have a legal guardian, there is a kind of Venn diagram of who is involved in this whole party. So you have the parent, and then the next person you have to consider, number three, is the MD, or the surgeon, right? Now, this is, no matter what you do, there's a lot of risk to the surgeon to make sure that this artwork that you just created is safe to return, right? So they have to have the last approval on this. So as part of that Venn diagram, you have the MD, right, the surgeon. All those people have to be in line in order for us to make this decision. So if the MD says, okay, well, with a brace, I'll okay that with a brace, and as long as all functional testing and questionnaire and subjective rating are above a certain percent, I'm good with that. They feel safe. Okay, great. So now we have this player who potentially can go back, but we have to also get like the green light from the other person, which is number four, which is the coach. If the coach is in line with this, and they say, you know what, they're a superstar player, I need them in the game, and we have, they have to do a risk assessment as well from a performance standpoint, is do they have easy versus hard games coming up? And what that allows them to do is make a decision, is this going to impact the outcomes of my team? So they have to do that internally, and then they have to decide, is this person fit to come back? Not just like physically, but also their endurance or their actual anaerobic and aerobic capacity. And then what's their skill like? They've been probably out of the game for a while. So they have to do their own risk assessments. And once they do that, now all you're doing is putting all the pieces together. So now we have the coach within that Venn diagram. And then part of that, you have the PT. And if they have other members of their team, great, put it on there. It may have a nutritionist or sports site, whatever it is, if you're in the pro world. But ultimately, in the community world, this is how we have to look at, well, what do we do to get to that next level? So first, you got to make sure that the athlete is in it to win it. The parent is good to go. Then you have to go to the surgeon. Once they've demonstrated that they're in it to win it, the next part is, what happens to that surgeon? Do we move forward to asking them, because now the athlete's asking for it? Do we ask for that brace? The next thing is the coach going to be in line? Now, if the athlete says yes, the parent says yes, the MD clears it, the coach clears it, all you're doing is now you're looking at the summation of all the scores to make sure that this person's ready to rock and roll. Now, what would you do knowing this case? If the athlete is good to go, what do you do? And this is a case that we brought up as a team. And there's no perfect world, especially in the pro world. It doesn't exist. There's always tough cases. So you have to ask yourself, number one, is it safe? Right? Above all, do no harm. Right? It's like our ethos. Do no harm. Do not put somebody in a position that is not safe. Well, if their hop testing and everything else is in the 90%, I mean, now maybe it's not a green light, maybe it's a yellow. But are you really seeing any reds? Absolute reds. Let's assume, oh, and good quality of movement, right? No dynamic knee valgus. That's pretty clean. It's really just delayed strength gains. So is it safe? And then number two, what are the options? What should I do with this? Like, even if I say yes, am I going to say yes to like full throttle, go back to sport? Or are you going to do modifications? What's your modifications? What are my options? So these are the options that you need to consider. Are you going to allow them, if they have a 1 month ramp up time? This is the art of mapping out whiteboard sessions, return to play and plan of cares. Now, are you, if this person has a month, so 9 months, and they have to go 4 weeks out, can they get to playing within 4 weeks? So you have to kind of draw that backwards. And in the first week, you're assuming now you got to introduce contact. Now, what percent? This was the question. What percent? Like, how do you grade contact? Is it total time under contact? Is it number of contacts? Are you deliberately like challenging them a bit? But what if they're in practice? How do you quantify that? So we came up with a couple numbers, and I want to share this with you. So total playing time and contact time are the two variables we looked at. Number one, playing time was we were going to build up with 10 to 20 minutes. Whatever, now you have to play with the coach and understand, okay, well, are you even going to be practicing with, are you doing sprints? Are you doing shuttle drills? Are you doing cat and mouse? Whatever it is. So now you're getting 10 to 20 minutes of multi-directional work and how much contact. So now we had to say, well, how do you quantify that? So we said 25% of practice can be with contact, 25%. So if it's a total of an hour, you get 15 minutes. So now we just have to go into different quadrants of the return progression and say, well, can we go now 50% contact on the following week with 15 to 25 minutes of play, and then go 75% return to contact, and now go 20 to 30 minutes of play. And the problem is, what you're not going to know is, can the knee handle the volume of change of direction and impact? And so that's where your options have to go. So maybe that might be too much. So then you change up your actual percentages, and you say you're going to go 5 to 10 minutes of playing time, 10 to 15 minutes of playing time, 15 to 20 minutes of playing time, and maybe 20 to 25 minutes. That might be more realistic for somebody. And percent of contact, you might say 25, 50, 75. And then by the time they get back to sport, you're potentially leaving them at 50 to 75, or I doubt you're gonna be able to get 100% contact for the full time. You're in practice anyways. So what you might do is literally say, keep them at 25, 50, and 75 at week 4, and then allow them to have 20, 25 minutes in the game. Now, with all of this, this gives a coach a little bit of framework. You have to appreciate that. Now the coach can understand, okay, well, how long do I put them in? Are they allowed to play, 30 minutes, 10 minutes? I mean, are allowed to go to full contact in practice? What can and can't they do? So what option one would be, now you can do multi-directional work. Multi-directional. Then you can do, with multi-directional work, you can go 25% contact. And then you can do 5 to 10 minutes of actual playing time. Now, you might say, well, gosh, that's not a lot, Chris. It doesn't matter. What you need to understand is, what is their expectation? They want to play and participate. You're giving them something, a goal to reach for, as long as it's safe. Just remember that. And you're just giving options. And then now when you add in that and you just progressively overload those variables, you're in a good place. Now this person will work with you. And most of the time I see physical therapists, one of the worst things that they do is they say an absolute no. It's like a parent. I'm I'm a parent. I have 3 kids, and Zach, Alex, and Jacob. And one of the worst words I can use with them is no. And I realize that more than ever. And I see a lot of physical therapists, especially new grads or getting to the established kind of second phase of 4 years, so from 4 to 8 years, they're still saying no. And when you work in the pros, in pro athletes and pro sports, I remember numerous times where I try and do this, and they're like, "Nah, I'm going to do it." And you're like, well, this is your job, so I kind of can't override that unless it's like complete contraindication, right? Like that's very rare. But if it's not a complete contraindication, why are we saying an absolute no? Because we're used to working with people who accept that. What if you have working with athletes, the bell curve, right? So when you give an absolute no, that's probably okay to the back 10% of people who are used to being told no, and they'll accept anything that they give them because they're not super motivated. Then you get the top 10% on the pro athletes or very highly motivated people. Those people will not accept a no. They're like, that's fine. You can say no you want, but I'm going to work. I need to work. And that's literally their job. So the middle pack of 80% in the middle need modifications. And you need to be able to provide that for people. And I think we're so quick to say no, and we rely on the surgeon to do so much, that I think that having a little bit of wiggle room and offering people different things that they can potentially have, and then you work with the surgeon, you work with the coach, and you work with the parent, everybody wins. Actually, the athlete wins the most, and there's a lot of buy-in, and it gives them opportunity. Think about this. If you had a son or daughter or family member who wanted to do this, you would totally figure it out. But what's the difference when you have people or clients or patients or athletes that are unrelated to you? It changes, right? And that's because you want to play it safe. You don't do, we don't want to be too risky. So my point is that I think that you need to consider some other options. And there's a lot of lessons I took away from this, and I want, and for those on YouTube and looking at my graph, sorry for my illegible writing. I can't even help it. But for those on the podcast, just know there's a couple takeaways that I have on this, and I want to share those with you. After hearing the case, now you know I'm going to now share everything, the 3 or 4 things that after hearing this whole thing that I would highly recommend you consider. And when you are looking at athletes and you say, hey, what are some of the biggest concepts you've learned along the way that you would highly recommend new or established people, established physical therapists, would not do or do given this type of scenario? Number 1, you can't realistically expect that every single athlete is going to hit 100% or 90% or 95%. For those of you who've listened to my podcast over the last year, months, whatever that is, there's a magic number that I use, and that's 90%. I need 90% across hop testing, everything else, subjective rating, questionnaires, you name it. Any number, I just need 90%. And that's just with treating hundreds, thousands of ACLs and rotator cuffs and everything else. It's just kind of the number that I've seen that really works, but that combined with everything else involved in the case. So this person did not have 90% with muscle girth and muscle testing. So this is an exception to the rule, but there's tons of exceptions all over the place, and they're hitting you. You're just not paying attention. You're just being the no parent. You're being the parent who's saying, "Don't touch that. Don't ever do that. Don't do that." There's a lesson my wife taught me a couple of years ago that I didn't realize I was doing. I used a lot of absolutes when I spoke with her, like the kids and everybody else. She's like, "You always say never or always," or I was like, "Oh, I didn't realize I did that." And as a parent nowadays, I'm like, I can't use that very often because I'm sure there's an exception somewhere. And so the more I I parent, the more I look at mentoring and coaching physical therapists, I realize there's always some wiggle room in the opportunities that you can give your patients and athletes. It's just knowing those. And no one ever told me these things. I just kind of learned them. And I don't want you to have to learn them the hard way. I'm telling you, I am sharing this with my team because this was so monumental in just being able to understand that not everybody's going to hit those 90%. And you're going to have cases that you need to reassess the sum of all tests. You can't assume that one test or two or five or 10 are going to be, you need to have 90% in all of them in order for them to safely return to sport. Now, 80% of the population, you probably might, but there's going to be 10% of the cases that you see that don't match. Like some are at 90, some are at 80, some are at 72.6, some are at 99. And you have to have some wiggle room. So have different options and modifications available. Okay. Number two, percentages are guidelines. And the sum of all tests combined with the athlete's will, like their desire, their absolute will, is a better, it paints a better picture. And just know that no one test will do it. And that's, I guess, the same thing with special tests, right? Like you're looking for a rotator cuff repair or a tear, you're looking for labral tear. You're going to do at least 2 to 3 different tests to kind of confirm that. And that's the same thing with return to sport and an ACL. Number three, in this case, this athlete knew what it was needed to get to a return to sport. And they knew that 90% subjective report was important. So they started saying 80s and 85s and 86% and 89%. And why was that so important is because you have to be aware that you don't want to give the athlete every single test that they have to pass, because what they'll do is they'll train for the test. And if you let them know what the test and everything that's going to be on it, they'll just study the test. And once they study the test, is that actual, like, is that a false positive? Are they testing well because they've practiced the test? So don't, as you go on to rehab, don't outline every single test. Let them know as they go along the way. And if you let them know everything too soon, they're just going to practice the test and they possibly can go around that. And so the last one, here's my priority for triaging return to sport clearance. Now, hearing this case, I said 90% on a battery of clearance tests. So 90%-ish with a battery of tests that is a sum of it, along with the athlete's desire and will and parent. Number two, the athlete and parent must want it. They have to want it. If they don't, we're pushing something that doesn't deserve to be pushed. Number three, you need to have the MD clear it. This is their baby. Like they literally like did this. They are like a big part of this whole rehab process. And you don't want to override them. Give them an opportunity to be successful as well. And lastly, that the coach, the sport coach, allows them or will allow them an opportunity. If not, why are we pushing all this? If the athlete doesn't want it, the parent doesn't want it, the MD doesn't want it, you don't want it, and the coach doesn't want it, don't worry about it. But all those people need to have support in this entire role. So our role is to navigate and support this entire algorithm to make sure they're set up for success and safely return to what they love and want. A lot of times we find ourselves as a regional provider, like I'm going to work on your knee, I'm going to work on your back, I'm going to work on your neck. No, you're facilitating getting somebody back to something. It doesn't matter. If you're not, I don't know what role you're playing within this planet of the profession. You literally, your job is to get them to something, a target, going back to school, picking up their grandkids, going to school, going back to soccer. There's a target. And if there's no target, you have to ask why you're even doing what you're doing. So in this case, you're trying to make sure that they're safe and they're following the path and the roadmap. Your job is to guide them down that roadmap. And with this case, you need to get other people involved. So I want to share that. Don't think you're on an isolated island as a physical therapist managing ACL. You work with a team of individuals to help an individual who happens to have an ACL repair safely go back to the thing that they desire, which in this case was soccer. So don't think that you're on an island. Don't think that there's absolute percentages. Don't think that there's one way to manage this. there is some wiggle room. So I will continue to provide updates on this case. It's a great case. If you have any questions and you want to know more, let me know. Dr. Chris at drchrisgarcia.com. And as we progress through strength and everything else, I'll share more of the strength testing and everything, the periodization that they're doing. And that's a perfect opportunity for a lot of people who are interested in cases like this. I will be having a strength and conditioning summit for those who are like, they love these cases. They love transitioning back to sport. They want to bridge rehab and performance. I have an event July 23rd and 24th, 2022, whenever you're listening back to this. And my goal is to be able to help clinicians with the early phases of rehab. A lot of us know the basic, first 3 to 4 months of rehab, and you can build whatever exercises you want within that. And my goal is to be able to give you the framework on the back end as well to transition people back into performance and sport in a safe manner. So if you're interested and you want to know more about that course and that event, let me know, Dr. Chris at drchrisgarcia.com. But I'm excited to see you guys there. Nonetheless, I hope you guys are doing well. As I mentioned, I am coming off a great cryotherapy session. I feel fantastic today. And life is good. So there you have it. If you guys enjoy these whiteboard sessions via YouTube as well, just let me know. For those of you on the podcast, I highly recommend come take a look. It's the feedback I got from a couple attendees at my accelerator course in March. One of the things that they mentioned was, can you do more whiteboard sessions? So on my YouTube channel, I have more of those. It's really just the algorithm and the processing, like how would you manage people? What does that sequence look like? What does the plan look like? So I'll continue to do that. And it's all these case studies and everything that the podcast reflects is for people like you. So keep giving me the feedback. All right, guys, I will see you guys on the next episode. Take care.